certainly my pleasure to be here this morning, and thank you so much for inviting me. I'd also like to acknowledge that Gisela Becker is here, and she is our co-author on everything that we're talking about from our research in the North. Just to let you know, my clinical training is in nursing. I worked in the delivery suite at BC Women's for many years, and I'm also trained in midwifery, although I never practiced as a midwife because it wasn't regulated at the time that I was trained. Okay, so I wanted to make a few comments about what we need to think about when we're reading midwifery literature. And that is, what we need to study is the outcome of where you plan midwifery, because we are trying to inform women's choice, as what was said earlier. So we know that when we start midwifery, we start planning birth at home, you may end up in hospital, but we need to know the consequences of where you plan to have birth. And so that's why studies of midwifery have to take into account the planned place of birth, that the women actually meet the eligibility requirements for low risk, that we know who the midwives are, that we have comparison groups which are of the same similar low risk status, that we have large enough samples that we can look at rare outcomes, and that we have standard definitions, and that we have involuntary reporting. And I raise this because much of the literature coming from the U.S. uses the American birth certificate, which doesn't take into account whether the birth was planned at home. So you have a lot of data from unplanned home births, and there's many, many different kinds of midwives in the U.S., including midwives who don't have any formal training. And so when you hear statements from the American College of Obstetricians and Gynecologists saying the rate of infant mortality is 3 times higher after home birth, they're talking about data where they don't know the qualifications of the people attending. So I just wanted to make that point to start with. And so I'm going to be talking about some outcome studies and also some economic analysis of home birth. So this was a study we did in BC in which we looked at all planned home births attended by regulated midwives, and we compared them with women who met the eligibility requirements for home birth but were attended by a midwife in hospital or a physician in hospital. And so again, we had all of the planned hospital births attended by a midwife for the whole province, and a random sample from physicians that were matched on year of birth, parity, hospital where the midwife had privileges, single parent status, and age. And this just shows the comparison with the planned midwife-attended births at home versus hospital. And you can see here that there were fewer interventions and fewer adverse outcomes in the home birth group. Now that doesn't mean that home birth is better, because we didn't do a randomized controlled trial of this, but what it means is that with the system we have where midwives screen for eligibility for home birth and women self-select to have home birth as well, that we did not see any excess risk associated with home birth in British Columbia. And then we did the same comparison looking at planned home birth with planned physician birth in hospital, and again you see those differences emphasized between the comparison with the births at home with midwives and hospital births with physicians. And our study was really important because it was probably the first one in which we had the same midwives doing the home and the hospital births, so it really isolated the effect of place of birth and allowed us to study the safety of home birth. And then looking at neonatal outcomes, the green is the home birth, and you can see that those adverse outcomes were lower in every category except the last one, which was admission to hospital after home birth. And when we explored that further, we found that those admissions were related to neonatal hyperbilirubinemia. So babies that needed to go under the lights had to come to hospital for that, whereas had they been born in hospital, they would have just had that treatment while they were there. But there weren't any other reasons for readmission to hospital that were in excess for the home birth group. So I wanted to show you this because this is looking at across a number of studies. So the first 3 studies were in 2009, and all of these studies met the criteria that I spoke about earlier. And so you can see the similarity between our BC data and the Ontario study done by Eileen Hutton. Very low rates of perinatal mortality here at 1 per 1,000. And then there was a massive study done in the Netherlands. And again, very, very low rates of perinatal mortality. And then these two studies here have just been done. They're 2015 studies in which the Ontario group repeated their study, and so did the Dutch group, and exactly the same very low risk and good outcomes for them. So I wanted to talk a little bit about the costs of midwifery care as well. And this is the first economic analysis of midwifery care that has studied babies throughout the neonatal period, and for the mom up to 8 weeks postpartum, and then again the whole first year of life for the baby. And this is important because if there were adverse delayed outcomes associated with home birth, we ought to see them here. Brain injury, for example, showing up in the first year of life, delayed postpartum hemorrhage for mothers. And so these are the costs that we looked at, and I'll explain each one of them. So for medical service plan billings, we were just looking at physician billing, and then we had the data on midwifery billing for the time of birth and postpartum. And again, it's important to realize that all of the outcomes associated with planned home birth were attributed to the home birth group, even if they ended up in hospital. And so the home birth supplies are now picked up by the province. That's about $50. And then for hospital costs, the way that this is done is that when someone leaves the hospital and their chart is coded by the health records people, they're assigned to one of about 25 categories which reflect the intensity of their care. So if you had a spontaneous vaginal birth, no complications, you'd be a case mix 1. If you had a forceps vaginal birth with no complications, you'd be a case mix 2. And it goes up to 25. And so what they've figured out is what the resource intensity use would be with each of those categories, but then how to attach a dollar figure to that. So what they do is they take the entire hospital budget and they divide that by all of these weights. And then for each person that's in the hospital, and this is different for every hospital, for every year, we have this data, we multiply the cost for case mix 1 for that hospital by the resource intensity weight to come up with a dollar figure for each person. And that's how we did this economic analysis. For our ambulance services, we don't have costing data. We can't take into account the cost of the fuel, etc. And so we just decided to attribute the costs that people are charged if they're not covered by provincial insurance. And then for our drug costs, we took that from our PharmaNet records. And for federally paid people, for example, people on reserve, we also had the amount that people received, and we could attach provincial rates to that. And so these are our findings here, and this is looking at the mother, and you can see here that obviously the physician fees were the lowest in the home birth group, hospital costs the lowest, transport higher, which is what we would expect, midwifery fees about the same in the two midwifery groups, drugs lowest in the home birth group, and they have the cost of the supplies. So this is the average total cost for a person in each of these groups. You can see it's lowest in the home birth group, and the midwifery group was slightly higher than the hospital group, and this difference here was just due to fee differences. And in this time period, physicians were paid very low amounts for taking care of healthy women, and that's why you're seeing low rates of fees for physicians. This is looking at the same thing for the baby, and again, much lower costs in the home birth group, and about the same in these two groups, slightly lower for midwifery hospital births. Again, these were all groups of comparable risk status. All these women met the eligibility requirements for home birth. And this is the same data, but just in a graphical form. So this group was statistically significantly less than the other groups. And this is now looking at the mother up to 8 weeks, and you see the same pattern here, so much lower in the home birth. And these two groups about the same. And then baby up to 1 year. Again, this is the only study that's ever looked at this, and cost to the healthcare system much lower amongst the babies born at home. And again, most of that reduction in cost related to the fact that they weren't in hospital being cared for around the clock by nursing staff and others. And the same thing in graphical form. So I also wanted to share just some of the work that we've done in northern Canada. And we went up to Fort Smith to work with Gisela and Leslie Paulette there. And we compared outcomes in Fort Smith with outcomes in the eastern maternities. And what's different about the eastern maternities is that women there are only funded to go south for their birth if it's needed according to their risk status. Whereas in Fort Smith, women that chose to go south for birth would be funded to go south for birth. And this is a very complicated slide, and I'm only showing it just to make the point that when we tried to compare women in Fort Smith with the eastern maternities, they were actually different. And so we had younger women in the eastern part. We had more first-time moms in Fort Smith. We had much more smoking in the eastern maternities. We had more anemia in the eastern maternities, so we had to control for those things when we looked at outcomes. This is just looking at Canadian data here. And so if you look at induction of labor, lower in Fort Smith and Nunavik, cesarean section much lower in both the northern communities. Preterm births, our national rate is 8.2, was higher in Nunavik, but quite a bit lower in Fort Smith. And small for gestational age or poorly grown babies much lower in the north. And this is information on transfer. And what this shows us is that actually about 44.8% of women gave birth in Fort Smith, where they could go south and be funded, and 86.3% of women gave birth in Nunavik and were not transferred out. Of people that met the requirements for community birth, about 75% of those actually did plan to stay in Fort Smith. And of the ones that were planning to stay at Fort Smith, about 80% successfully completed their birth in Fort Smith. And overall, about 49% of women were cared for by midwives in Fort Smith, the rest having gone to Stanton or elsewhere to be cared for by a physician. When we looked at the transfer rate, the reason for it was 62% of the time that something had come up that required a transfer, and 37% of the time by choice. And among the transfers, about 44% were in intrapartum. So that just kind of gives an overview of the transfer scenario. And these are now comparing the Fort Smith outcomes with Nunavik, because we were trying to get some kind of comparable community. And so these are odds ratios, and they're adjusted for the differences between the different populations, age, parity, smoking, and previous cesarean section. So what this shows us is that there's decreased rates of blood loss and postpartum hemorrhage in Fort Smith, and increased rates of epidural augmentation, induction, and cesarean section, although still low rates. And when we looked into this further, we found out that these excess interventions here were amongst the women who had chosen to go to Stanton for their births. So among the women that had originally planned to give birth in Fort Smith, there was actually no difference across the groups in rates of interventions. And this is looking at newborn outcomes. So we had more breastfeeding initiation in Fort Smith, and we had a few more low APGAR scores at 1 minute, but no difference at 5 minutes, and then no difference in any of the other outcomes we looked at, fewer preterm births in Fort Smith. And now we're looking at Hay River, and we also wanted to do a comparison with a community in which evacuation was mandatory. And so no babies give birth in Hay River during the time of our study. And because of that, it was very difficult to find data. We went to get data from public health nurses, and therefore we have fewer outcomes to look at. So what we found here is that in terms of maternal outcomes, fewer cesarean sections in Fort Smith, fewer rates of induction, and then looking at perineal tears, no difference. And then looking at newborn outcomes, there was really no difference across the board in terms of women who were required to leave the community in Hay River or stay in the community in Fort Smith.
Just going to move the mouse up.
Oh. Okay. And then I just wanted to briefly say that we did qualitative work also at Fort Smith. We did focus groups with women, asking them about the midwifery program and what was the meaning to them of giving birth in their own community, what were the challenges, and how they would like to share their stories. And so the themes that came out were their trust in the midwife, the feeling that they were very well informed and knew a lot about the choices that they had. They talked about how difficult it was to imagine leaving their children and how wonderful to be able to stay with them and to be able to have the support from their family and friends in the community, and also the tremendous postpartum follow-up they had with the midwives as well. And I just wanted to also mention the importance of evaluation and evaluating from the very first birth as you think about your regulations. So one of the things that we did was we developed kind of a perinatal database for the North, and this incorporates a lot of the data around transfer, which is of particular importance for northern communities. And so this is developed on an Excel database, which is your very, very sort of common, simple software that you can use. And it has a place where it can all be entered, and then it shows up in an Excel spreadsheet, and this spreadsheet can be imported into any statistical package for people to use. So I just wanted to encourage you to think about evaluating from the very beginning. Our database is big and complicated, but it can be whittled down to whatever you want. And I'm finishing early here, so we have some more time for discussion and questions.